Well, thank you, Cam, for that very kind introduction. And also, thank all of you for coming here tonight. Wondering if I should, these mics are on, and I have one of these mics on my tie. Maybe I'll just leave this mic on for now and use this if I need it. So today I'm going to be talking about occupational disease prevention, which is certainly one of my favorite topics. I never know now, so many times you speak, you have to do a conflict of interest. Cam's already said where our center is funded from. Our core non-competitive funds come from the Ministry of Labor, as well as the Canadian Cancer Society, and Cancer Care Ontario, which hosts our unit as well. Initially, when the unit was created, also we had funding from the WSIB, and the United Steelworkers also played a key role in getting us set up as a unit. So enough of that. Occupational disease has certainly been in the news, I think, more now than it has been at any point that I can remember, at least occupational disease-related stories. I've kind of picked some out here, or with the help of Kate Jardine, who works for the center, picking out some headlines that deal with issues that our center actually deals with. So there certainly is more stuff going on out there than this, but at least gives you a little flavor of why this is now becoming to be in the public eye, and I think getting more attention. One of the things that I hear sometimes in some of these stories quoted back is, well, you know, now there are more people getting occupational disease than there are dying of traumatic injuries. And that's been presented for things, graphs like this. And this is just cancer. You can see that cancer in Ontario, fatal claims exceeded traumatic injuries about 15 years ago. And if you add on the occupational diseases, it was longer than that. The other occupational diseases would be another 20 or 25% more. So it is increasing, but it's a phenomena of increasing recognition and accepting of occupational disease claims that led to this. In fact, this is not a new problem that just grew out of nothing. There has long time been a problem with occupational disease, and it just hasn't been as well recognized. Well, now it certainly is front and center, not just with here in Ontario with our Ministry of Labor, and I'm very happy that we have our Occupational Disease Action Plan and the implementation team going, but this is also going on in a number of other provinces. BC, Alberta, Manitoba, Newfoundland, all have things that I know of, and I know that there are other provinces that are doing things as well related to occupational disease. So this is a good time to try to move forward on this issue here in Canada. Now, in that previous graph, it said, you could see that occupational disease was exceeding it and looked like it was twice, maybe 3 times as much. The ILO actually estimates that ratio is more like 6 worldwide. So for every traumatic injury death, there are 6 occupational disease deaths. But that ratio is much, much higher in industrialized countries where we've been, gratefully we've been, driving down our workplace injury deaths. So that ratio is actually higher here. So this is definitely a large issue, and one that really does need to be addressed at this time. Now, the Occupational Disease Action Plan has a lot of folks involved in it, and there's a lot of familiar faces in the room, and a lot of you have been involved in it, and certainly if not your organizations. But you could see that there was a big cast involved in this. I'm going to apologize. I'm getting over a cold, and I'm going to be a little bit raspy this evening. When the implementation for the Occupational Disease Action Plan was going on, there was an exercise we went through to try to prioritize occupational exposures as to which ones might be the most important to take on first. And in doing that, we were looking at how much exposure there was, so the prevalence of exposure, the need for prevention, the potential for impact, and the opportunity to kind of combine efforts with other organizations. And you see here about these 12 exposures over here on the right-hand side. And initially, what was decided to do was to take the top 3 of those and form working groups to try to get something going on those 3 exposures. And all in all, 5 working groups were developed. I'll talk about the last 2 in a minute. But the first 3, here they are, noise, allergens and irritants, and diesel engine exhaust. And although we don't always know the prevalence of exposure, sometimes we at least have an estimate. So noise is certainly a very common, excess noise is a very common exposure. If we take data from BC, which does a lot more audiometric testing than we do and has, I think, a more solid number, and we apply that to our numbers here, we get up around 350, 400,000 people exposed to excessive levels of noise. And we have approximately 5,000 to 8,000 claims per year for noise-induced hearing loss, but that really only represents a very small proportion of those diseases. The same thing when we get to allergens and irritants. It certainly is a common exposure, but here we don't really even have great estimates for numbers of people exposed, and there are many allergens and irritants. But approximately 1,000 dermatitis claims, smaller numbers of asthma claims, and some other respiratory disease claims represents only a very small proportion of the burden. And diesel engine exhaust, we have a Carix Canada estimate here of 300,000 people exposed to diesel exhaust at work. And our Burden of Occupational Cancer Project has estimated that there's about 170 lung cancers annually caused by diesel exhaust, and probably another 45 or so bladder cancers caused. And we don't even have estimates for the number of cardiovascular disease or respiratory diseases that are caused by diesel engine exhaust. So all of these are big hitters, but they do represent a diverse bunch of exposures and diseases. Now, you've heard kind of a recurring theme here of the difficulty of recognition of occupational disease. And back when I used to have to teach medical students about occupational disease, and typically in many of our medical schools, there's a series of modules like that, and they pull people like myself out to teach those. We would talk about the difficulty of recognizing. And although maybe with new developments in science, we may at some point be able to recognize what causes a disease by simply doing a test. In fact, the clinical and pathological expression is what I would tell the students of a disease does not necessarily vary by its cause. So you can't go by how a disease looks for the most part, with some rare exceptions, which I'll mention later and are probably obvious to everybody here. But what you have to do is you have to take an occupational history, and that's because, particularly for chronic diseases, they'll show up a long time after the fact. Dose is always important. So the higher the exposure, the higher the risk for almost all diseases, and it's hard to know that. And the earlier you know it and start collecting information, the better. The other challenges are that most diseases have multiple causes. It's true for almost all chronic diseases. So it's not just that a disease has one cause. Everybody, well, not everybody, but certainly I and many people I know have an older relative who smoked a lot and never developed cancer. Does that mean smoking doesn't cause cancer? No, it means that there's more to it than that. So we always have to think about those multiple causes. And it may also be that people vary by their susceptibility. So the last 2 groups that were working groups of the Occupational Disease Action Plan were the Intelligence and Decision Support Group and the Electronic Medical Records Group. And these are important because what was recognized from the onset is that we need more data to drive database decisions or evidence-based decisions in this province, and indeed in every jurisdiction in Canada and easily in North America. And so these 2 committees were set up to try to facilitate that. A long-term goal is that it becomes part of the electronic medical records, which not only puts it into the electronic medical records, which it isn't now, but it also means that it encourages all of our primary care physicians to ask patients about their work history, which is something we have to do. And then we also have to develop the systems, the data systems, to really get a better picture of what's going on. Now, Probably many of you have seen this report that came out a while back now, last year, on the burden of occupational cancer, and it was put out by the Occupational Cancer Research Center in collaboration with many others, and supported by the Cancer Care Ontario unit that does these kind of reports, the Population Health and Prevention Unit. And one of the things I'll say that if you can't measure it, then maybe you can model it. And so this really was a modeling exercise to take everything that we know, and we know a lot about what causes occupational disease, and to try to model it and see just how many diseases we believe are caused by work. This is the bottom line of that. If you add up the number of cancers that are in the kind of middle column there, you'd arrive at about 3,500 cancers per year, just due to this list of very well recognized workplace carcinogens. And there are many others that are out there that have varying levels of proof. We took the ones that were, for the most part, what we call group 1 IARC carcinogens here, so ones that have a substantial amount of proof. And what you'd also see is that there are still millions of people in Ontario in many different walks of life that are exposed to these kind of exposures, that they're carcinogens, but they also cause other diseases. And it just happens that we were able to estimate this with the carcinogens better because of the depth of data that we have. Now, an example of what we can do, I'm going to use asbestos for that. And asbestos is timely because, as many of you know, we legalized pot here in Ontario. And that same day, they actually passed the bill to finally ban asbestos in Ontario. So unfortunately, it didn't get the kind of press that I would have liked it to get, and the kind of attention and fanfare that it deserves after so many decades of so many people trying to work to get that change. Anyway, this is a timely thing, but it's also one of the most important exposures still in terms of really fatal occupational disease. The impact of mesothelioma across Canada, in terms of simply work-related exposure to mesothelioma, is about 500 new cases per year of mesothelioma. I might have been repeating that. I'm just going to drink a little water. But actually the biggest impact is on lung cancer, because when you look at studies, North American studies of asbestos-exposed workers, for every case of mesothelioma, you have 4 or more cases of lung cancer that are in excess in that population. So asbestos, the single biggest target for people getting cancer, is actually lung cancer. Now, Emil Tampa, who is part of our burden of cancer group here, who's here today, I'm happy to see. We had a group there trying to estimate the economic burden of cancer, and that's been published, and I'll talk about that in a second. $2.3 billion annually in economic costs associated with just the mesothelioma and lung cancer cases. And there are smaller numbers of other cancers here that are harder to estimate the precise number. In addition, there are about 80 silicosis cancer, or silicosis, scarring of the lungs, deaths per year here in Canada. But also there are likely thousands of people out there that have scarring of the lungs and some degree of impairment due to silicosis that we do a much poorer job of counting. Now, this is just to mention the economic burden portion of this Burden of Cancer project, because it's a very important component. And it's one that we really need to bring home, is the economic costs. It is something that I think we can use to help drive prevention, but it is staggering in the long term. To me, of course, the number of people who die and suffer is more important, but I think this is still going to help us push forward the prevention messaging. Now, to get back to that theme of recognition, we used the number of cancers that I was presenting in the previous slide was the number of newly diagnosed cancers. But if you look at the number of fatal cancers in Canada caused annually. We calculated that as well. And here you see the numbers on the left in orange for lung cancer and mesothelioma, the number of fatal cancers. We looked at that, and our estimate was for 2011, and then we looked at the average number of claims per year that are accepted for those two cancers as an average over the following 4 subsequent years, because usually, oftentimes, these things are filed after the unfortunate fact of people dying. And what you see is that even for mesothelioma, and mesothelioma is one of those diseases that beats all the rules that there really shouldn't be a lot of questions about when you see mesothelioma. Overall, we're getting about 60% of those are being compensated in Canada now, based upon this calculation. And albeit it's indirect, but I think it's not far off. And when it comes to lung cancer, then you see it's about 5%. So even though lung cancer is the single biggest impact of asbestos exposure, only 5% being compensated. What I've also listed here is we've broken that out between men and women, and what you see is a large disparity. Occupational disease is much more poorly recognized in women than in men. And that's an important thing and something that we need to change. We have less variability, but we do have variability when you look at things geographically. So we used data from the Association of Workers' Compensation Boards of Canada to calculate this. And you should know, and people can easily say that it doesn't reflect the precise number that come out of each province each year, but it was reported by those provinces at a time, and it is collected, so it was what we had available. What you see is that Ontario is just about on average, which you see in almost all statistics because we drive the average. But Quebec being just slightly better, and the one thing that I think is the most different here is this number for British Columbia, and that's because British Columbia now has an ombudsperson to assist people with mesothelioma in compensation. Now, I want to make clear that I don't think that there's any jurisdiction that I know of that does great overall on compensating cancer. That's a challenge for all those reasons that I presented before. But it's important to recognize that when we talk about things, that when we talk about compensated disease, it is not all occupational disease. That is to be something we remember, or we're simply grossly underestimating the problem, even for perhaps the most well-recognized cause of fatal disease that we have. Now, mesothelioma is one of the few things that we can generate lots of descriptive statistics on. And here you just see the number of incident cases of mesothelioma plotted. This is a bit out of date, but you see it plotted per year in men and in women, more slowly rising in women than in men, and maybe some evidence of a plateau that we're on now. The national numbers of mesothelioma continue to rise, but that appears to be driven by Quebec and to a lesser extent by British Columbia. So we need to analyze this statistically, and we've been funded by WorkSafe BC to do so, to do some comparative work between Ontario and British Columbia, as well as to look and project by province how we're doing with this. But this kind of brings up this point that these kind of chronic diseases arise decades after we've actually mostly addressed the problem. Now, we still have a lot of asbestos exposure, but it's nothing near where it was in the mid-1970s. And another sign that we're dealing with something that isn't simply random occurrence is how different it varies across the province. These are the rates of mesothelioma by public health unit in the province of Ontario. And you see, I've just put the cities there, not to point them out for negative reasons. although Sarnia is the highest, and Lambton County is the highest rates in the province, but also just to give people a little geographic anchors to look at. But where I didn't mark there, which is Toronto, is statistically lower than many of these other areas around the province. And we are able to plot this even on the public health unit level, even with our reporting rules about numbers of cases. The one thing that isn't something that you can pull up easily on any kind of these diseases currently, except on the compensated ones, is what people's occupation and industry was, and what the risks are among different groups. And for that reason, we created the Occupational Disease Surveillance System with funding initially. The pilot work was done initially with funding from the WSIB. Then the Ministry of Labor kicked in funding. And then we presented it as a model to the Public Health Agency of Canada that never does this kind of thing at all. And they accepted it as a novel and important thing to do that maybe could even be a model for other provinces. So the Public Health Agency of Canada has weighed in on this as well. Now we have funding from both the Ministry of Labor and the Ministry of Health and Long-Term Care to continue this project, where what we do basically is we take people who had time loss claims over a number of years, and we follow them subsequently to look at what their risk of disease is in the following years and decades. And so we now have a large data set, over 2 million people, where we have those kind of occupation and industry information to look and generate those kind of statistics, and to do it not just for cancer, but for hospital data, for physician visits, for ambulatory care visits. And this is what it looks like for mesothelioma and asbestosis, just to give you an idea that the system works. It does generate what we think are the usual suspects that we know are at increased risk, and some of them at massively increased risk, like insulators in construction, plumbers and pipe fitters, and boilermakers. But you see there also many other groups, and overall the increased risk in the construction trades, but also in mechanics that deal with industrial and farm and construction equipment, stationary engineers and others, where we see both mesothelioma and asbestosis elevated in many of these groups. A group that I think we've been concerned about, but we have, I think, fairly clear thing here, is educational and related services. And it's important to recognize who's in that group. We're dealing here with a group of people who had time loss claims for injuries, for the most part, that we're following subsequently. So this is a lot of our custodians and the skilled trades people that maintain our schools. And any school in Ontario that is older than the 1970s, older than the 1980s, probably the mid-1970s, has asbestos in it. We removed the lagging around pipes initially with a provincially funded program, but all of our public buildings had asbestos put in as a safety measure. And so it exists. It exists in the ceilings and the floors, behind the walls in many places. And we had this philosophy that we weren't going to remove it because it would cause more harm than good. That's what I was always trained back in the mid-1980s when I was trained as an occupational hygienist. And I thought asbestos was a problem of the past. But meanwhile, we're back here now 30 years forward, and that asbestos hasn't been removed, and those buildings are 30 years older. So I think we have a real challenge facing it, in the future about how we're going to remove that asbestos. So occasionally I'll editorialize tonight, so I'll apologize in advance. I will say that we can look at other diseases, and I want to just give some examples. So we have some results for asthma. I've just picked out selectively a few results, but these are groups that we know have exposure to allergens or irritants that would be associated with asthma, and we're seeing excess risks We just got basically a conditional acceptance on a paper that'll be coming out soon, so we're very pleased about that. In the Annals of the American Thoracic Society, so a good, solid journal, specialty journal which is quite a great one for us getting into, which we're quite happy about. But in any case, this is really done with outpatient visits really driving things, and it's looking at new onset asthma. So we put in a period where you can't have anything in your medical records that said you had asthma for 3 years, and then asthma starts appearing at least twice in that year, and then we count you as an asthma case. So these are new onset asthma cases. You'll remember that diesel exhaust was one of our priorities for the Occupational Disease Action Plan. So we just looked at some groups that we know are exposed to diesel engine exhaust. Now, what you see here is an increased risk of lung cancer here. And I should have explained that HR is a hazard ratio. It's a form of relative risk where a ratio of 1 means it's the same as everybody else, and it starts getting higher than that, it's an increased risk. So 1.1 is 10% higher, 1.8 is 80% higher. And then there's the 95% confidence limits. But what you see here is a lot of the groups that are exposed to diesel are at increased risk. So that's what we expected. The challenge is that a lot of these groups also have exposure to other workplace lung carcinogens. So it's going to be a hard thing to tease apart. But certainly in the excavating, paving, and grading type subgroup of the construction, you see a very clear pattern. A lot of our transportation groups are there as well, where there might be a chance for people, I suppose, to have other exposures, but it's less so the case. And stationary engineers, where we also can remember them from the previous slide that dealt with asbestos. I'm going to give a few other examples here, and I don't want to be unfair, but sometimes when you set priorities, it matters who's in the room. And so if Ron House was in the room, it might have been that hand-arm vibration syndrome and vibration would be one of our top priorities. And indeed, it's one where there's been a lot of good research and work done here in Ontario. And yet, here we see some of the groups that we know are exposed to upper extremity or whole body vibration, and we see an increased risk, interestingly enough, using ambulatory care data. This is an interesting one for us to look at. All of these, I've picked out the risks that were greater than 50% higher, and ones that had enough workers, and they're all statistically significant. But I wanted to show you that, again, even with this disease, we're seeing a lot of interesting patterns. Now, I've been talking about disease surveillance, and in fact, I think we're making a lot of good progress on disease surveillance here in Ontario. And that's a great thing. But if we want to get ahead of the game, if we want to really prevent disease before it happens, we have got to start figuring out some way to get a handle on doing hazard and exposure surveillance. And that really is the best way to address prevention. Now, if you have something, that occurs quickly after exposure, there isn't a big separation. But for many of these diseases, we're not going to see that signal that there's a problem until much later. And there's a lot of uses for this kind of data. Monitoring trends, and I'll give you some examples of that. Trying to identify areas where we should focus our prevention efforts, setting those kind of priorities, and even for other forms of disease surveillance where we can try to calculate what our rates are of disease by exposures when we're not even sure what those are, which might be so we can look forward and identify new causes of disease. Now, some years ago, I started the Carex Canada project as a way to kind of at least generate some numbers, and again, most of you know I'm a cancer researcher, so I usually start with cancer. But this project was really meant to fill a gap, and I probably could say the same thing. If you don't have measurement data, at least what we can do is try to model it using the best expertise that we have. And really the CAREX project was meant to do that. And I think it's had a good impact over time in raising awareness and getting people, the understanding that these are not rare exposures that we're dealing with. But if we wanted to move to measurement data, we begin to get in trouble, even for I've put here some of the things that we really should be what we call data rich on, things where a lot of measurements have been collected over time. But what you'll notice is the dates in the top of there that represent when labs were closed in Ontario and BC, with the only major province, the only major jurisdiction that still collects a lot of measurement data being Quebec. And Quebec collects more measurement data than almost anybody ever has, because this is just 5 years and it's comparable to what these other provinces did over the entire period that they were putting exposure measurements into their database. So that's important. Sometimes you see quirky things. These beryllium measurements, as it happens, Quebec has, I think, the second largest set of beryllium measurements of any jurisdiction, because they had a very strong interest in it. But there are always sampling campaigns that happen at various times that we have to be careful of when we're analyzing trends in this data. But we can analyze trends and we can adjust for those things. And this is something, I've got a few slides here just to give people an idea of the use of that. Here is just a trend of wood dust over time. And what you see is that it does what we hope for. Levels of exposure were dropping over time. During that period, we were collecting measurements. But a health-based occupational exposure limit right now would be 1 milligram per meter cubed, which is a lot lower than where that ends over there. Did we ever reach it? Are we down to where we're much safer now? The fact is we have a big gap in our knowledge, and the only place we have measurements from is oftentimes the very best employers that are willing to share data. We don't have anything that's even vaguely representative anymore to be able to know what those trends are. And just another quick example of that is benzene. And here again, you see BC and Ontario. And this is from the Canadian Workplace Exposure Database Project, which is a sister project to CAREX, which we started some years ago, convincing many of the jurisdictions to give us all their exposure measurements so we could actually put them in the same format and look at trends. But then, the same issue arises that we hit a point where we simply can't measure anymore. Here we're pretty low, but the current, I'd say, health-based limit would be half a part per million. So we're still, where we ended up there, we're still not where we want to necessarily be, and we don't know how far we went down. We hope we're down there, but it would be sure more comforting to know that that was the case. An alternative way to measure exposure, at least in targeted populations, is to set up exposure registries. And sorry about that. I hope I last another 20 minutes or so. Exposure registries are actually have been quite good, and we have one of the best and longest standing international ones in the National Dose Registry, which is housed in Health Canada. It was started in 1951, registering everybody who is exposed to radiation, which is under federal jurisdiction, but the National Dose Registry is actually a federal provincial partnership. That's also a good thing. That means it can happen. And in fact, even though it's a federal regulation, all the provinces are collaborating on doing this. There are about 500,000 former radiation exposed, current or former radiation exposed workers in there that are tracked over time. The Asbestos Worker Registry here in Ontario is a bit of an alternate way of doing things. The radiation, we can actually put badges on people and collect measurement data long term. And asbestos, that would be very difficult to do, but at least with the Asbestos Worker Registry, employers are required to submit information on time that people spend in different types of activities or tasks that could result in high asbestos exposures. So that kind of model could be quite flexible. And I've just put a couple of other examples. Victoria Erndale has a paper out that was a kind of a group effort to look at these kind of exposure registries through a project that was funded by WorkSafe BC some years ago. And it's in the Canadian Journal of Public Health. If we really want to get ahead of the game, then this might present another way of doing that. Ontario is one of the few jurisdictions in the world that has a Toxics Reduction Act, and that requires major workplaces that use toxic chemicals to report not only their emissions, which is already required federally, but to require their, to report their use of chemicals, and also to produce a chemical kind of a prevention or reduction plan. Sorry, I'm not remembering the same thing. I can blame it on cold medications. How's that? But basically, an annual plan is produced, and all of this is public information. So we've simply been mining that. But with a few tweaks to this, we could actually be collecting more useful data for workplaces and make this not just environmentally focused, but also workplace focused. And that's something that we've been trying to do, and this is an example of that. And what you see is in different industry sectors here in Ontario, tons of usage, the top 3 carcinogens, the number of workers at the facilities that reported that usage. That may seem very simple, but that's not something that's readily available anyplace else. So this really is a useful set of data. And if we were thinking, for instance, even to the point of, oh my goodness, we got to lower regulation to, 1,3-butadiene, where should we be looking for, who should we be informing that we're doing this? Who should we be involving in any kind of regulatory consultation? Who should we be targeting for prevention if we know that there is use of this? This kind of data could really be quite useful to help drive that kind of activity. I will point out that it's a bit distorted in a sense because what's being collected here is how much is being used. So if you're a plant that's producing nickel products, in fact, a lot of it is going into the product. And if you're in the chemical industry, you're going to have lots of tons of use of chemicals. But still, it gives us an idea where that exposure is occurring, and you can be more sophisticated in how you look at this and think of this in terms of the potential for exposure, and sometimes then trying to find exposure measurements in those same industries. I'm going to switch gears here for the last little segment of this to more in the area of prevention. And I'm just starting this off by talking about the hierarchy of controls. Probably every occupational health and safety professional has seen this kind of thing. I presume almost everyone here is aware of it, but this is NIOSH's triangle where elimination is considered the top way. You simply eliminate the hazard altogether, substitution out. Those are the targets of toxic use reduction. But failing that, engineering controls, administrative controls, and then finally personal protective equipment. And then because it's often brought up as a prevention activity, I've put early recognition and screening at the bottom. And early recognition and screening is a good thing, but really it ranks below even personal protective equipment because people got to get the disease first. We don't want that to happen. So certainly in the course of these things, we really want to be focusing on actual prevention or primary prevention, as we call it. Now, I was recently part of a large kind of team effort headed up by Barbara Neese and Stephen Bornstein from Safety Net in Newfoundland, but really having a kind of a coast-to-coast team of different people involved in looking at promising strategies for primary prevention of occupational disease. And we chose, noise-induced hearing loss, dermatitis, asthma, and cancer. You might notice that there's a common theme here, and probably we're like pulling from the same pool of people for doing these things. But these are all important diseases that I think everybody recognizes across the country. And what we did was a scoping review and a series of key informant interviews. Looking at both legislation and regulations, including things like occupational exposure limits and inspections and how we even handle prevention in different places, surveillance and screening, and mostly workplace-based surveillance and screening, so not like these large province-wide efforts that we've been talking about earlier. Control measures across the whole range, education and training, so trying to increase awareness, and then multifaceted approaches. Now, we're going to have a report coming out hopefully soon. We're trying to submit the paper for publication and then have the release of the full report with all the appendices. And I thought I would just give it a couple of examples here. This is from the BC Construction Safety Association, and they have a silica control tool that they developed in collaboration with the University of British Columbia and Hugh Davies from the University of British Columbia. This is a very interesting tool that incorporates quantitative data where they're trying to look at levels of exposure with different tasks, and then levels of exposure with those tasks when you apply different types of prevention, control strategies. And so what somebody can use is, before they even begin a task, is try to estimate what the levels of exposure would be, what the hazard would be, and what control measures would be necessary to reduce levels of exposure. Now, people can, I think, have issues with every different level of this, but in fact, this is an attempt to do a proactive approach to controlling silica exposure in workplaces, which I think is a very, very positive thing. Started in BC, but now groups are looking at it in Alberta seriously, and I hear Manitoba now as well. Might make it to Ontario someday, who knows? There was also, because we had a national group, we tried to look also at how things are handled differently in other places. So Quebec has a very different model on this, which is they integrate their occupational health services into the broader public health framework, which is quite a different model than any other place in the country. In fact, their Occupational Health and Safety Act mandates the public health system to be part of this, and requires that local teams, which are interdisciplinary teams, actually take on these kind of efforts. And I think this is a great thing. A challenge that we have with many of these things is that we've got lots of great ideas, but sometimes we don't have enough evaluation to know how effective they are. And that's a challenge across the board with many of the things that we looked at in here. Only a small proportion of them had evaluation components, which I think is key. So we could find examples that were effective really in all the different categories that we looked at. In terms of legislation and regulation, effective certainly in certain contexts, maybe problematic in things like noise-induced hearing loss, but all of them require strong enforcement to be effective, and they need to be up to date, reflecting the current state of knowledge. Workplace surveillance and screening can also be an effective tool, although it really is something taken on by some very select types of bigger workplaces. But what you see here is that all of these things can be effective, and I think people felt the best about multifaceted approaches that really try to incorporate many of these things into really creating a program to control occupational disease. Now I'm almost to the end, which is good because I didn't want to go over time. And I wanted to mention another project that we're doing in collaboration with the Institute for Work and Health. And that is trying to use our burden of cancer models to try to project forward and say, well, how many cancers could we prevent if we institute prevention strategies, and when would be the payout for when we would start actually seeing prevention happen. Now, a challenge is that we use as our examples, sorry, I'll be doing a lot of listening after this rather than speaking, I hope. But a lot of these things, it takes decades to make a big dent in the number of cancer cases we're causing because these diseases have a long latency. But eventually, you do start to prevent diseases, and the costs of doing prevention certainly get offset. So there's both a component here of looking of when we start preventing cases of disease, and also when do we start producing enough of an impact of that to offset the cost of prevention in order to get a broader acceptance of prevention. Now, I probably haven't been doing a great job of explaining all my slides as I go along, but I'll just point out that we're talking here about the difference between wet cutting and dry cutting of stone and how much that makes a difference in reduced silica exposure. You don't have to be a rocket scientist to see that in these pictures. It makes a very big difference. And then the challenge is trying to get compliance with that. And so we modeled 80% elimination, 60% elimination, or full elimination. And what you see as, even at 60% elimination, we eventually start to get substantial numbers of cases prevented. But it happens sooner, much sooner when you get full elimination, that top line. So we have to take our prevention efforts seriously and really try to get as good a compliance as possible across the board on these. So, conclusions, finally. Preventing occupational disease has become a priority, not just in Ontario, and I think it's great, our efforts here in Ontario, but really across the country. And I think we can be feeding into each other's efforts across the country and trying to really look for the best practices going forward. We've made good progress, I believe, in the area of occupational disease surveillance. And we've developed some models that I think we can use effectively to produce the kind of data to drive evidence-based decision-making. We're still a long ways off from recognizing individual cases, but at least we can drive prevention and prevent future cases. We have much further to go with hazard and exposure surveillance. Hazard and exposure surveillance, I think, is the real challenge that we'll have going forward and being as proactive as we want to be in preventing disease. But we do have effective control strategies that we've identified, and I think our work now is to develop better ways to evaluate those, including assessing both their impact on reducing disease, but also starting to introduce economic evaluations in there, into really kind of pushing the message that we need to be spending a lot more on prevention. So moving our agenda forward, occupational disease prevention needs to remain a priority. More data is needed to drive prevention, especially in the area of hazard and exposure surveillance. And we still need more prevention research to identify the most effective ways to reduce exposure, and those research projects need to have strong evaluation components as part of them. I just ended with this little collage. I could have made it bigger if I had gone to the wide format. Just to say that, there's a misconception that exposure to hazards at work really exists only in a limited number of blue-collar occupations, but in fact, it hits a wide variety of occupations and a wide variety of people of all different kinds. So it really is a major societal problem. And I wanted to thank all of you for coming, but also I want to thank all of our staff of the Occupational Cancer Research Center and all of our students, as well as all of our research collaborators, a number of whom are here today, who together really made the research that I presented possible and really did all the work. I'm just the chief cheerleader for this, so I'm very happy to be proud of that group, or part of that group, and I'm proud of that group as well. So thank you very much.